Students have any particular character or anything of interest where they would like to start? We're discussing this morning the Seinfeld episode, The Masseuse.
I thought George's character was particularly interesting this episode. His whole thing about not being able to stand someone not liking him, and then at the end basically saying he's more attracted to women that don't like him than do like him.
So let's take the initial part of that and look at it a little closer. George Costanza in this episode discloses, self-reports that he feels uncomfortable and dislikes when other people don't like him. Now, it's focused on a single interpersonal relationship, but again, for those of you who have watched previous episodes and previous seasons, you understand that this is actually a pervasive thought of George. Any ideas as to what might support this, or any observations about this? Now, I mean, when I bring this up with students, it's sometimes a little difficult to kind of get over the initial barrier from this particular relationship. That is the teacher-student relationship. Your grade is dependent on it, right? So, and that goes across the board. We have undergraduates, graduate, as well as medical students that are listening in right now. But outside of the context of such established relationship, what's going on with George here? Because he doesn't need a grade. He doesn't need a promotion. He doesn't need anything from the individual other than his being appealing to them. So what's that about?
I was wondering if that was like a degree of social anxiety disorder, if that could classify as that, where he just kind of had these ruminating thoughts of like, do you think she liked me? Like, what was that look that she gave me? And just the constant rumination that happened afterward and reflection on that. But I wasn't sure because if that would actually classify or not, but that was my thought.
As an initial impression, there now needs to be follow-up questions that if we had the fictional character of George available this morning, this group would ask him. So focusing now, not necessarily on the character or what the character portrayed in the Masseuse, but generally speaking, if someone were to come into your office with a chief complaint that resulted in the clinician thinking that social anxiety disorder may be the single best answer, we could even apply this to a shelf exam. What is it that you want to know?
Like when it started, if there was any precipitating event, if it interferes with that daily life activities.
I'll give you that it interferes with daily life activities. And this one I will apply to George. We've seen this in this particular character ruin or sabotage prior relationships. So we've seen this, and because of the interpersonal dysfunction, yes. But as far as duration, precipitants, duration, not so much. We do know that it spans 9 seasons. Precipitants, the answer is going to be yes, doc, but I can't really put my finger on it. So let's keep that part vague. Ultimately, what do you need to know to confirm a diagnosis of social anxiety disorder in a patient, whether it's in a vignette or whether it's in a clinic?
I think you'd want to see fear and anxiety of social situations, and you'd want to also be able to rule out the cause of being from any other medical condition, or and then the patient would tend to avoid those situations that give them the fear and anxiety as well.
Exactly right. They may or may not avoid, but they definitely are going to have anxiety and fear and exactly as you pinpointed with regard to social or performance situations. How does that differ from agoraphobia?
So in agoraphobia, I think it's more or less you avoid situations where escape is like you feel like you can't really escape. So things like enclosed areas, crowded areas, public transportation, being in lines, things like that.
Exactly right. All right. So, and we definitely need to get to what the base fear is. If it's fear of escaping before becoming symptomatic or embarrassing yourself, we're going to call it agoraphobia. If it really isn't, and it has more to do with the social situation itself, performance situation itself, then we're going to call it social anxiety disorder. And in your case vignette on your shelf, you're going to have to tease that away. That's very, very important here. Question, do either of these apply to George?
I don't think agoraphobia would count because he's not exhibiting avoidance behavior. It's more just the distress that is happening that he's reflecting on. So I would think possibly more social anxiety, but yeah, and I don't think an agoraphobia would classify here.
Because you've diagnosed social anxiety disorder, you have now implemented a biopsychosocial treatment plan. The biology of it, the biological aspects or factors in the treatment plan certainly can include pharmacology, psychopharmacology. We're not going to really talk about that this morning. I want to focus the group really on the psychosocial interventions with regard to psychotherapy. In psychotherapy, what is something developmentally that you are likely to unveil after you establish rapport and after you meet with this individual for several sessions?
Okay, good. Okay, well, that's next 15 minutes.
Generally speaking, what's going on here when an individual requires someone else's impression of them with regard to their own self-esteem? It's part of social learning theory. It's called an external locus of control. And that's exactly what we're seeing here. Ultimately, what diagnostic label we put on the maladaptive behavior, the clinically significant behaviors, remains to be seen. Certainly, social anxiety disorder would be high on our differential. But I think the most critical element in this is, irrespective of what diagnosis we ultimately make, there's going to be a biopsychosocial treatment plan that is implemented. And the psychosocial aspect of that plan is likely to include therapy. And in therapy, and this is really the take-home point, we are going to focus on George's external locus of control. This character's self-esteem and self-image has everything to do with what people see in him and very little to do in how he sees himself. That is, there's an absence of an internal locus of control, right? And this is something that's very pervasive over the 9 seasons of the situational comedy. George manifests this in multiple settings across time, those 9 years. So external locus of control here is guiding George Costanza's behavior. He has this need for other people to like him. And if they don't, his sense of self-value is less than. And that's really important to understand here. Any other observations with regard to this character pertaining to this particular episode, the Masseuse? Just to close the loop on this, when you sit down for your standardized exam, when you sit down for your shelf, you are likely to get someone present to you with avoidance behavior. And I don't want any students to jump to the answer set and begin to look for what appears to be the single best answer, because as soon as you read A, agoraphobia, and B, separation anxiety disorder, you're going to get stuck, because the idea of clinically significant anxiety resulting in avoidance behavior really isn't teased away with regard to any of those or either of those 2 likely scenarios. Now I'm going to throw another one at you called separation anxiety disorder, which also can manifest as avoidance behavior. So before you peek at that answer set and get yourself more confused because A, B, and C can still be correct, know exactly what you are looking for in that case vignette so you can go right to the answer and get it correct. Again, if there is a fear of becoming embarrassed in that social situation, it's likely agoraphobia. If it is the performance or social situation itself, it's likely social anxiety disorder, otherwise known as social phobia. And then finally, if it's separating from, usually a primary caregiver, that precipitates the anxiety, it's separation anxiety disorder. That is, it has less to do where the person is going and much more to do where they're separating from. That's separation anxiety disorder. Again, the choice of normal behavior would be the single best answer if separation anxiety occurred at about 2 years of age, so 18 months of age is when it peaks. So the person in your case vignette must be significantly older than 18 months for you to then call that separation anxiety disorder. A quick rundown of the anxiety disorders that usually do present with avoidance behavior, and choice D at this point will also include post-traumatic stress disorder. PTSD is separated from all of the above due to as a result of the additional symptoms that you're going to see. Many more symptoms and traits of PTSD, including those that look like panic, that look like obsessive compulsive disorder, and that look like depression. So when you see that constellation of symptoms with the avoidance behavior, PTSD is likely your single best answer. Any other observations about George or any other characters this morning?
I don't have a character observation necessarily, but a comment was made about adopted children being serial killers in the show several times, which I think from what I read before, adoption, I think has been shown to be associated with personality disorder. I'm not sure if it's necessarily linked with antisocial personality disorder, which I think reminds me of the serial killer picture. That was just an observation I made. I'm not sure if I'd have to research more to go if they're just throwing out a stereotype or if there's something rooted there that they're playing off of.
Largely a stereotype. So there's some creative liberty here with regard to the comment that adoption and serial killers have a link. That is in fact not the case. On standardized test, on different exams, you can see the link between adoption and future mental illness in general, but not necessarily antisocial personality disorder, and not necessarily any personality disorder for that matter. But mental illness, yes. Serial killers, no. Now, having said that, individuals with psychopathy and even antisocial personality disorder will have a very consistent childhood that is marked with, clinically significant and severe disorganization, right? So what is often referred to in clinical circles as the psychopathic triad: cruelty to animals, destruction of property, and bedwetting. Bedwetting, especially when outside of the appropriate developmental period, is a sign of interfamilial discord. That is, the child does not deem their home environment to be safe, right? So, can adoption then increase the risk of that? Possibly, but we're talking about an indirect correlation there. What is the more important idea and what is the more direct correlation is that there's just discord in the family unit with regard to the child's perception of having an unsafe home environment, right? So psychopathic triad. So of course, early childhood physical and sexual abuse, I think, is the overwhelming example here. As well as, a lot of other things that could contribute to the child determining that their home environment is not safe. We'll talk more about psychopathy today during our 12:30 lecture. We'll apply it to the fictional character of Elijah Price.
I have a quick question regarding what Thomas just mentioned. So would that be an example of any of the like defense mechanisms with this generalization? I was trying to think of which one it was and I couldn't think of that, but just like you have one example of someone doing something, like maybe one time there was someone who's adopted who was a serial killer, and then you use that as like a fundamental idea to ground your further thoughts, but I couldn't put a name to it.
No,
If that makes sense.
I think your idea of generalization is correct. I wouldn't name that a defense mechanism, though. I would name that a cognitive error. You know, if we're going to look at it as a subconscious, of cognitive error, you know, cortex, that's consciousness. If you're going to look at it as a subconscious process and want to come up with a defense mechanism, that could occur. Maybe rationalization, but I think it's probably more of a cognitive error. I think it's more localized to the cortex, and there certainly generalization would be part of our differential or case formulation. And again, I think, you know, in CBT, and we just had a great grand round that introduced this, albeit in a little bit of a different direction. But in CBT, the idea here would be that those cognitive errors are persistent to a point where it results in clinically significant deficits in functioning. Right. And that's exactly what the therapist then would focus on. And you know, we see this with Elaine too. I mean, her interpersonal relationships will always end up the same way. And the cognitive errors do not only apply to her thoughts about adoption and serial killing, but a lot of other, I think, automatic thoughts, catastrophizing thoughts that seem to sabotage her having any meaningful relationships as an adult. Any other thoughts? Got 10 minutes to go here. Any other characters you want to discuss this morning in the Masseuse? I think one of the things that might come up on an exam, certainly in identifying the antisocial personality disorder, again, I brought this up before, it's definitely worth repeating. The cardinal trait of clinically significant disregard for and violation of others' rights is going to be then defined and supported through different observed behaviors and traits. What the American Psychiatric Association came up with regard to their checklist, that is their diagnostic criteria, really focused primarily on traits. Because of the absence of identifiable behaviors, the Hare inventory scale was created that of course then included those behaviors and then separated the clinical term psychopathy from the clinical diagnosis of antisocial personality disorder. And that idea might come up on a shelf exam in some context. That the absence of identified behaviors in the original checklist that right now sits in the personality disorders chapter of the DSM-5 is compensated for by the Hare inventory, which diagnoses or screens for psychopathy. So antisocial personality disorder plus those items on the Hare scale equal psychopathy. Any other characters do anything in this episode that warrants your clinical attention?
I thought Jerry in this episode, his behavior made me very uncomfortable. I think that was intended, but his whole thing with the masseuse, I just kept wondering why he couldn't just ask her for a massage and he had to try and get it through like sneaky, you know, backhanded ways, like trying to manipulate her into doing it. The whole thing sort of seemed like an allusion to, I don't know if prostitution, but definitely like questionable consent. Like it was not a comfortable scene to watch, and his behavior was kind of icky to me.
I agree with you. I think that was in fact intended. I don't think there's any mistake there. I'm not sure we would even use the term questionable consent. I don't think there's any question about it. There was no consent provided. In psychiatry, the allusion here would not only be to rape and molestation, but keeping it more clinical, probably some sexual deviancy, which allows us to then render an opinion as to why Jerry may have been so hesitant to actually put words to his feelings and what he wanted from her. I think the massage was a metaphor for something that was taboo, that Jerry couldn't directly talk to his girlfriend about. And then when he heard his best friend engage in such an act with his girlfriend, he felt that violated all boundaries. So very symbolic, but I think it does prompt a discussion of the sexual deviancies, if you're going to keep this clinical, and then refocus us to the sexual disorders chapter of the DSM. I don't think there's any particular sexual deviancy that is identified in this particular episode, or at least I don't recall as such. I think if Jerry were to come with a chief complaint of anxiety or depression because, doc, my relationships never work out, and we began to focus on this most recent breakup, and we heard this story, I think the clinician would be prompted to review the sexual disorders chapter of the DSM. Actually, in the DSM-5, there's 3 chapters dedicated to the sexual disorders, one of which are the paraphilias, the sexual deviancies. And we could review those more in detail today. By the way, just again, for completeness sake, as we're coming to the bottom of the hour, if the sexual deviancies are one of the 3 chapters dedicated to sexual disorders in the DSM, what are the other 2? Gender dysphoria is a diagnosis that has its own chapter. And then the final one are the sexual dysfunctions. For test-taking purposes, I would strongly encourage medical students to bring up an image of the sexual response cycle and then refer to your favorite board review guide. And in looking at the chapter dedicated to the sexual dysfunctions, what you'll notice is that there are around a couple for each level, each phase of the sexual response cycle. Much easier to kind of then categorize and then remember any sexual dysfunctions that may appear on your shelf exam. About 5 minutes to go. Any final thoughts? Any other observations or characters anyone would like to bring up? All right, we'll leave it here. We'll look forward to beginning rounds. We're one big team this morning, so I'll leave it up to the respective residents as to what team will round first, but we'll look forward to the morning rounds beginning at 9 a.m. So I'll see everybody then. Thank you.